Good morning, everyone. Great good morning to everyone who has joined the Breakfast at UM panel. My name is Dr. Goh. I'm from the Department of Otorhinolaryngology from the Sleep Division. I'm proud to present today with the first speaker, Dr. Ong Hui Yan, or Dr. Grace Ong, is a good colleague of mine and a friend I've known for the past 9 to 10 years already, since my time in Hospital Tengku Abang Rahimah. She's a dedicated clinician, lecturer, and researcher in the field of otorhinolaryngology head and neck surgery, and is now pursuing a special interest in the management of sleep disorders and ENT, and of course in sleep medicine. She currently serves as a clinical lecturer in our department as well, and very involved in teaching, clinical work, and research. Her research and academic work has been widely recognized and multiple publications in international journals, including one in robotic surgery just recently. She has also presented her work in numerous conferences, including one in Mumbai recently, just 2 weeks ago. She was invited as an international speaker. And this also includes national conferences like the Malaysia Multidisciplinary Sleep Conference, MMSC, and Malaysian International or LHNS Congress. Working with our sleep team, she also actively manages patients with sleep breathing disorders and is also training under transoral robotic surgery for APOM. Without further ado, I would like to introduce her speech. Her topic today is a very interesting topic. Her topic is about women and sleep, which is something we hardly neglect. We often see males and obstructive sleep apnea, but this time we want to focus on the female gender in sleep disorders as well. So without further ado, I would like to pass the mic and the session to Dr. Ong. Dr. Ong, Dr. Grace, please, the floor is yours. Thank you very much.
Thank you, Dr. Julius, for the kind introduction. So now I will share my slides. Okay, so a very good morning to everyone. Thank you for joining our breakfast talk today. So for the first talk, I'll be presenting on women and sleep. So as an introduction, everybody sleeps and we need sleep to improve our health, healing, memory, as well as our ability to function well throughout the day. So sleep is a complex process, and actually there are many factors that can affect sleep, and one of them is our gender. So women's sleep is different from men, and because of these differences, there's also differences in how sleep problems between these two genders present, and this can contribute to misdiagnosis. So previously, all biomedical researchers, they normally use a 70-kilo male as the standard to study human health, and hence females have a lack of appropriate medical care and attention. So recent decade, there's a sharp rise in scientific publications on the topic of women and sleep, and now there are more efforts at the organization level to advance women's sleep health. So according to this sleep medicine physician, women are not only affected by hormonal fluctuations that change their sleep experience, but they also carry invisible burdens related to relationships, careers, or societal expectations. So these factors undoubtedly play a role in their ability to get to sleep, to stay asleep, and to function during the day. So besides being different in terms of physiological aspect, like there are differences in terms of the circadian rhythms, such as the core body temperature and melatonin levels. For women, sleep is also affected by the variation in reproductive hormones and also the different roles that they are playing in life. So in this slide, this shows some prevalence of sleep disorders among women. So as high as 30% of pregnant women and 42% of postpartum women reported poor sleep. As for perimenopausal women as well as postmenopausal women, 25 to 30% of them actually reported poor sleep. They only have good night's sleep only a few nights per month or even lesser than that. So all these statistics are actually quite significant. Women tend to rate their sleep quality lower than men according to studies, and anxiety and depressive disorders associated with lower sleep quality are twice as common in women. They are also more prone to develop restless leg syndrome, and the and it is as high as 25 to 50% risk. So although we know that men are 3 times more likely to be diagnosed with OSA, but actually post-menopause, the prevalence of OSA in women is just the same as men. So regardless of the age and also the BMI, occurrence of OSA in females increases twofold following menopause. And there are distinct manifestations of OSA symptoms between male and female, with females reporting more issues with insomnia and fatigue, as well as mood disturbances, while males generally report excessive daytime sleepiness or even snoring. So when females have OSA, they are also having an increased risk of developing heart failure greater than men. So this is something that we cannot avoid, we cannot ignore. So upper airway resistance is also affected by our menstrual phase, with lower resistance being observed in the luteal phase compared to the follicular phase. So if we do our diagnostic study at a different phase of the menstrual cycle, OSA may not be picked up. So this is something that is possible, and so we have to be a bit more careful when dealing with female patients with OSA. And also because the fat mass distribution between men and female is different. So males, they tend to have visceral fat distribution, while in females, fat tend to accumulate around the upper airway as well as the neck. So these can contribute to OSA. Women are also known to be more likely to be diagnosed with insomnia, and because they have different hormonal phases and they experience discomfort during pregnancy, breastfeeding, and even during infant and child care, or when they are in peri or postmenopausal period, they have nocturnal vasomotor symptoms. So all these actually can complicate can worsen insomnia and also complicate insomnia treatment, and hence they require special treatment considerations. So, physiological wise, like I mentioned earlier, there are differences in the circadian rhythms between men and women. So, the melatonin is a hormone that helps with the timing of circadian rhythms at sleep, and it is secreted much earlier in women compared to men. Core body temperature also reach its peak earlier in women compared to men, and hence, generally, women actually experience the urge to sleep earlier than men. They are the early chronotype. And women's intrinsic circadian period, which is their internal body clock, is also shorter than men by around 6 minutes. So every day, their circadian rhythm is shorter. So over time, there will be a misalignment between the central body clock as well as the sleep-wake cycle. And this effect is actually very significant, 5 times more significant in women than in men. So because of all these differences, men tend to sleep a bit later and compared to women, and men tend to have a less consistent rest activity schedule compared to women. But women because of the misalignment of the sleep-wake cycle with the circadian rhythm, they tend to have more insomnia problem, while men has more obstructive sleep apnea problem. So following sleep deprivation, females also can exhibit a greater activation in motivational and reward processes. They will tend to overeat also, but males in general tend to overeat at a greater degree in response to sleep loss. So because in female we have our menstrual phase, so reproductive hormones actually influence sleep and circadian rhythms a lot. So women, especially in women with premenstrual syndrome and also women with premenstrual dysmorphic disorders, they can have sleep-related complaints like insomnia, frequent awakenings, unpleasant dreams or nightmares, and also during the daytime they may have fatigue and also unable to concentrate properly, especially during the premenstrual week and during the first few days of menstruation. During pregnancy phase, so hormonal fluctuations can affect the sleep-wake cycle. On top of the hormonal fluctuations, they can experience anxiety, urinary frequency, backache, fetal movement, general abdominal discomfort, breast tenderness, as well as heartburn symptoms. And all these actually make their sleep poorer. So during the first trimester, women tend to sleep longer and experience greater daytime sleepiness. During the second trimester, daytime sleepiness improves, but shortly after, when the third trimester comes in, there will be increase in sleep disruptions because of the nocturnal nocturia, because of the fetal movement and all. So they typically have 3 to 5 awakenings per night, and they have diminished daytime alertness as well as more disturbed dreams. So 21% of them actually report very disturbed sleep to the level which is consistent with the diagnosis of insomnia. So this is actually very significant. So poor and insufficient sleep during pregnancy are associated with increased level of inflammation, and this can result in poor health and also adverse pregnancy outcomes such as intrauterine growth restriction as well as prem delivery. And because during pregnancy, generally pharmacological treatments are typically avoided, and hence they continue to have poor sleep during the pregnancy phase. So women during the pregnancy phase, they are also at increased risk of developing OSA. This is because of the growing uterus, which elevates the diaphragm, and also because of the hormonal changes. Neck circumference can increase. Nasal patency can be reduced because of inferior turbinates, engorgement, or pharyngeal edema. So all this contributes to OSA symptoms and can lead, if the OSA symptoms, even at mild OSA and all, can compromise the mother as well as the fetal health. Postpartum phase. So for postpartum phase, 6 months postpartum are also there because of the need to care for the infant, and also because of the hormonal fluctuation. There will be an increase in wake after sleep onset and hence reduce the sleep efficiency. The fatigue and the lack of energy, which persists from pregnancy into the postpartum period, can last through the first year after delivery. Although from studies, sleep begins to normalize about 3 to 6 months postpartum, which is around the time when the infants begin to distinguish between day and night. But I think as parents, a lot of us know that it actually persists much longer after that. So as for the menopause phase, small percentage actually, a small percentage of women suffer from symptoms which is severe enough to interfere with their ability to function effectively at home. So because of all the vasomotor symptoms like hot flashes, night sweats, insomnia, mood changes, fatigue, and excessive daytime sleepiness can occur. So the prevalence of insomnia in peri and postmenopausal women is estimated to be as high as 38 to 60%. So in conclusion, these are some common sleep disorders in women, like restless leg syndrome, because they are very much at higher risk, insomnia, as well as OSA symptoms, or upper airway resistance symptoms. So what are the common symptoms of sleep disorders that we have to watch out, especially in women? So symptoms of insomnia, they might find it difficult to fall asleep, lie awake for long periods at night, unable to initiate sleep, wake up a few times during the night, or wake up very early in the morning and they were unable to get back to sleep, or they have depressed mood, difficulty concentrating, or they are more irritable than usual. As for restless leg syndrome, these are the common symptoms. So it is normally rest induced and it gets worse during evening and at night. So the leg will feel it will have leg aching and also has a strong urge to move, and it gets better with activity. So this can affect sleep as well. OSA symptoms, I think a lot of us are quite well versed with the symptoms. So generally, men complain more of snoring and excessive daytime sleepiness, while women's symptoms are more subtle, which is like mood disturbance, insomnia, or tiredness or fatigue throughout the day. So when should we actually seek for help? So symptoms of if you have a very disturbing symptoms of sleep, and also it is disturbing your daily function, then it is wise to seek professional help. Or if the symptoms, despite your effort to improve it, has been persist for more than 3 months, or if you have OSA symptoms and or without the medical complications. So online we can find a lot of screening questionnaires and all, but if you are not sure, better seek professional help. So yeah, so all these are actually the medical complications of OSA. And if you have all these like uncontrolled hypertension, diabetes, and also heart problems, arrhythmia, and all and also difficulty with weight like obesity, then on top of that, if you have OSA symptoms as well, better work it out. So the management of sleep disorders will involve a multidisciplinary approach. So after the screening and the evaluation, so it depends on what sleep disorders. Generally, it will be managed in a multidiscipline way. So besides the sleep team, and primary care can get involved as well with the management of chronic medical problems. Maybe psychiatrists will have to give their input, and if it is hormonal related, pregnancy related, or then we will have the ONG colleagues to help out as well. So there are many treatment options. So depends on what sleep disorders that the women has. But like generally for women, because of the hormonal problem, so pharmacological treatments for menopausal insomnia will include hormonal replacement therapy. So with or without any psychiatric problems, then the antidepressants and hypnotics and as well as sedative may be useful. So herbal or dietary supplements to improve sleep, acupuncture, yoga, exercises are some of the things that can help to relax the body and also to improve sleep health. But generally for insomnia, cognitive behavioral therapy is very much recommended, and it has been shown to be beneficial for the long term. So in order to promote better sleep also, our diet is very important. So high fiber diet, low sugar and plant-based diets promote better sleep, while high saturated fats and refined sugar in diet can cause insomnia. So if you are not eating properly or taking too much of unhealthy snacks, all these can worsen conditions like OSA and insomnia. And because of the poor sleep, it leads to cravings for unhealthy food, and hence the whole cycle can repeat. So diet is actually very important. Sleep hygiene is another field that another part that we always advise our patients if they have any sleep disorders. So these are the general steps of sleep hygiene: keeping our room at a comfortable temperature, keep your bedroom quiet and dark, avoid alcohol, try not to go to bed on an empty stomach or overeat before you go to bed, avoid smoking and alcohol, and also avoid vigorous exercise before sleep. But within this general sleep hygiene advices, screen time is not included. So actually smartphones and tablets, they emit a short wavelength blue light that can suppress melatonin. After only 2 hours of exposure, it can cause the sleep latency to increase more than 30 minutes. That means there will be more than 30 minutes, you will have more difficulty to initiate sleep. So limiting electronic device use in the bedroom may be helpful to promote better sleep. And pertaining to women, because of the hormonal shift, so cool night temperature as well as lightweight pajamas may be useful during times of hormonal shift, like when we are having night sweats or hot flashes. So in order to protect our sleep time, maybe can consider adjusting caregiving roles with our partner, and also consider partner sleeping behavior. If they do have snoring or some other sleep disorder which can disturb your sleep as well, so consider getting treatment so that both can sleep better. And because women tend to be more sensitive to noise, so maybe, and also men tend to sleep later, so if they are disturbing with maybe because of the video games or whatever. So maybe earplugs or white noise machine may help. So in conclusion, although women spend more time in deep sleep and they tend to sleep a bit more, they experience more fragmented and worse quality sleep. So when compared to men, they are more likely to experience insomnia, they are more likely to get restless leg syndrome, and they are more prone to poor sleep because of chronic pain as well as because of the hormonal shift. So, and because women perceive and report their sleep problems differently compared to men, sleep disorders can go misdiagnosed or undiagnosed. So it's very important that we look after our sleep health. And if you have any sleep disorders, symptoms, always seek for professional help. So across our woman's lifespan, sleep disorders and sleep disturbances are actually very common, and this can bring the negative impacts of poor sleep is beyond tiredness and fatigue. It can impair our daytime functioning and mood. So it's very important to identify and treat all these disorders in order to improve the woman's quality of life. The International Women's Day is coming up, so I wish everyone, all women, happy International Women's Day. So love ourselves, prioritize our sleep, and if you have any sleep disorder problems, always seek for help. So these are my references. Thank you very much.
Thank you very much, Dr. Ong. I would like to also stress that World Sleep Day is just 2 weeks from now. So uh, I think everyone should practice good sleep hygiene, and of course, not just for the women and also the men as well. I hope the conversation has been very fruitful. We'd like to open the questions to the floor if there are any. Thank you very much. Okay, I have a question from Sarah Ahmad. Thank you for the question. Dr. Ong, what nice talk. Thank you. How does one manage restless leg syndrome? From Dr. Sarah Ahmad, how does one manage restless leg syndrome?
Okay, so actually for restless leg syndrome, normally what we need to do is besides taking a clinical history, we need to investigate and find out what are the possible causes of restless leg syndrome. So most of the time, sometimes it can have some iron deficiency or some other electrolytes problems, and also besides the history, blood test is also something that is very important. And generally, we will also advise to do a proper sleep study to rule out other causes, and then to also to see whether is it a periodic lymph movement or is it associated with other sleep disorders. And then after that, we will try and see whether any lifestyle changes or any dietary advice will be helpful. If not, then medications.
I just want to add on a bit on this management of restless leg syndrome. Actually, this restless syndrome is quite it's a fairly complex type of situation whereby it's not just necessarily due to iron deficiency. Sometimes we see a lot of patients with neurological disorders, Parkinson's, nephro-related issues, nephrology. We often work together with these teams to co-manage with them. Very often we give iron supplements, and if that fails, very often we can give certain medication like gabapentin to help them. Those are medication that we can consider. And of course, I think all these lifestyle modification, Grace, like
Yeah, correct.
exercises like you have mentioned, and of course, good sleep hygiene is there to help the patient. But in our own practice in the hospital, we've noticed that quite a lot of them do come with multiple comorbids, and that should be
Yes.
managed together with restless leg syndrome as well. So that's my opinion. But my point is, I think for what's important as a practitioner is that I think some of the other departments other than the sleep division or even ENT or even respiratory, we often overlook the parameter of limb movements. So I think we should pay special attention, especially when they have a lot of comorbids. Okay, I think we have a next question to Dr. Grace. Does sleeping on the side help with better sleep by reducing airway hygiene by Dr. YK Chan? Thank you very much.
Okay, in terms of the position, technically, if you're lying down supine, because of the muscle laxity and all, and also because of the gravity pull, it does have some impact on the airway resistance. But we will normally, if we can do positional therapy, is actually part of our OSA, one of the therapy that we can suggest. But before we actually go about it, so we need to take complete history and also to see overall how bad is the symptoms. And when we do a sleep study, we can actually know that whether the OSA, whether the apnea or the hypopnea happens worse at which, whether is it in the supine position or in the side position, then we will know whether positional therapy will actually help that particular individual. Um, so of course, sleeping at the side may be helpful, but you need to get a proper diagnosis as well as a proper diagnosis and investigation to see how severe it is first. Because if it is a very severe obstructive sleep apnea, positional therapy alone will not be very helpful.
Thank you, Dr. Ong. I just want to add on a bit on the positional therapy part. I think when it comes to positional therapy, it's very much useful on certain type of sleep apnea. And this is what we call positional OSA. Huh? And that is usually diagnosed from the sleep studies. And the AHI value of a supine versus non-supine is actually double of that of non-supine. And I think there are many strategies. I think Grace would know this as well. We can use tennis ball. We can use a special pillow that we can help the patients. But very often, if they are very fall into the category of severe, the symptom does improve, snoring reduces, but it does not. It is not eliminated in most cases. So I think it's very much dependent on your sleep study. If your sleep study does show certain features that is responsive to position therapy, we can definitely give that a try as a primary therapy. But overall, I think the main treatment and the first line of treatment is still CPAP. And a CPAP should be tried first, and subsequently a positional therapy can be definitely complemented in a lot of cases. I hope that answers Dr. Chan's question. Grace, anything you want to add for positional therapy from your own experience?
No, I totally agree with your answer.
Yeah. I
Yes.
think pregnancy, especially right, pregnancy, we see a lot of positive therapy because a lot of pregnant women, they don't want to wear CPAP, so they attempt positive therapy, and they may not get advice from doctors, but they actually naturally do it.
Yeah, and
Am
they
I right?
actually feel better, I think, lying to the side and all. Mostly also because if you are lying supine, I think the pressure of the fetus over the blood vessels and all will be very significant and very difficult to breathe lah. But yeah, but if you don't know how severe it is, then for severe OSA, positional therapy alone will not be helpful lah.
Yep, agreed. The next question from Sarah Ahmad was, how do you use a tennis ball? Yeah, it's a very good question. Grace, you want to explain?
Maybe
Yeah,
Dr. Julius, you can explain. I think
yeah.
you can Google the image from Google, and then it will be quite interesting. Actually, is to actually prevent you from lying down there, because if there's a tennis ball at the back of your body, then you feel uncomfortable if when you lie down to that side. So I think that's how it helps
You,
to not want you
this
to
one,
lie down on that side.
yeah, this one actually what we call cara kampong lah. They use a duct tape. They strap the tennis ball at the back. They strap it at the lumbar area, and then just to cause some, when they lie down on the flat, then they feel pain, so they are forced to sleep on the side. So that's how they do it. The next question by Chan Yu Ken, Dr. Chan Yu Ken. CPAP causes dry mouth and many patients find this uncomfortable. Yes, we agree with that. That's why, I mean, if everyone is aware of the current market trends, a lot of people who purchase the CPAP device online, or if they want to just purchase it online, very much needs a doctor's consultation, because we have also found that in our census of patients that start CPAP, almost half or more do not really like CPAP because of that reason, whether it's dry mouth or masks,
Or bloatedness.
difficult
Yeah.
to, yes, difficult to wear the mask, or maybe they're not comfortable with wearing machine, or even carrying the machine around might be difficult for them. We need to provide them an alternative, such as oral appliance. And if they have a structural issue, maybe we should consider some form of surgery, for this type of patients. In most cases, if they do have issues with the CPAP, optimization is very important. So it's not just about purchasing the CPAP and that's the end of story. You need to be on consultation by a doctor for us to really adjust the CPAP to the patient. So for example, if the patient has a very bad nose block, which is very often seen by us, medication should be started for these patients. And we need to optimize as much as we can. Dry mouth is very much a consequence of two things. The first one is the machine does not provide enough humidification. And the second thing is the other issue is the mouth breathing, you know. When a patient has a lot of mouth breathing, they tend to breathe cold air into their throat. That's why they feel a lot of dry throat. So this all needs to be seen by a doctor and consultant to actually assess the main issue and treat the issue accordingly. Right, Grace? I think we see a lot of cases like this
Yeah,
every week.
correct.
Right.
So if you have any sleep disorders or any sleep problems, you are very much welcome to come to us. So Dr. Julius is managing the sleep team and I'm practicing under him. So we welcome everyone. I think thank you from us. Maybe we can go on to the second talk.